So I'll start out with this comment that so successful innovators adapt and thrive by developing opportunities and choices. Opportunities and choices that most everybody else doesn't. That's how you successful and thrive. You develop opportunities and choices that the rest don't. And it's not a best practice. So if you're looking for best practices tomorrow, I would say stay open. Because by its very definition, our answer is not a best practice. But someone's going to make the new best practices. So you would say, oh, that's good, that's fine, that's great, and that's good because we're smart, and I'm smart, and we got a great organization that's really innovative. Well, the challenge with that is the data is just overwhelming. That historically successful, and I make four comments: mindsets, methods, strategies, and structures. M2S2, you can think of it that way. Historically successful mindsets, methods, strategies, and structures will always seek to slow, stall, or stop certain kinds of adaptive innovations.
Now, you can lose weight with just about any diet or gimmick. Almost anyone can. But the ultimate onslaught of the wrong environmental messages, the wrong environmental cues, the wrong environmental contingencies, that is, what you get rewarded for or punished for, pretty much assures that we'll keep returning to the unhealthy behavior. There are no brakes on the bad eating habits and the lack of exercise. People end up regaining the weight. We get a tremendous amount of misleading information and bad guidance from everyone around us who should know better, and it's really frustrating because we know what the answer to this problem is. Skinnerian conditioning works.
But what is the real problem? I had a question mark at the beginning. Was the problem Mr. T, or is the real problem this? That we're in the era now of the multi-conditioned patient. We have a log jam of things, tasks to do, and there are 75 million people in this country with 2 or more chronic conditions. We're entering the era now of the multi-conditioned patient.
What we need to do is truly understand people at a much more granular level. And really, who are they? What is their behavioral set that makes up who they are and what they do? And really understanding that from the aspect of confidence, their knowledge and skill sets, and their true ability to see themselves playing a role in their healthcare.
So one of the single greatest challenges that we see as a service provider is that in spite of delivering treatments, that the majority of our patients or participants relapse after successfully quitting. So this is a challenge. And what I'd like to do today is to tell you about a possible solution for addressing one of the primary causes of relapse that we've seen in treatment, which is patients expressing concerns about weight gain in treatment. And that solution is the Way to Quit program, and we've done a trial on it. I'm going to tell you a little bit more about that. The Health Quest program that we introduced last year was branded as well, and this is very typical for REI programs. Is we want to make sure that it resonates with our employees, so we branded it Health Quest as their journey to well-being. It was designed as very much like a frequent flyer program with key milestones, and it's a points-based system. At the first milestone, which is the trailhead, they are eligible to receive a premium contribution credit off of their annual contributions. And then throughout the year, there are challenges and activities that they're encouraged to engage in for additional points to get some additional rewards.
So I'm going to tell you the story in 15 minutes of how we've evolved to date, our health and wellness strategy and our programs. And to do that, I have to go all the way back to 2005 when Steve Bird, our CEO, who's a very smart business guy, looked at his health spend and trend. We're also self-insured, and said, we can't sustain this. We're a very low-margin business.
I've been studying healthcare, health practitioners, scientists, and technologists on the West Coast in Asia for about 3 decades. In the last 20 years, I've been studying Silicon Valley. and the Greater Bay Area. And I've also made forays into other communities, such as research I did this last summer in the Pacific Northwest. And I'm trying to understand the connections between work, so I'm the segue to the last few panelists, family, and community. And within that mix of work, family, and community, there is, of course, health.
In 2008, I also I've discovered the Quantified Self meetups, which had just gotten started a year earlier. Were founded by a few people from Wired Magazine, Gary Wolf and Kevin Kelly. And really, as you can kind of see from the list of topics here, it's really a fairly informal way for people to share things that they're measuring, things that they're trying to understand about themselves, and often trying to improve.
At the beginning of this day, when we were asked to raise our hands for whatever role we were playing, it was interesting to me that when we were asked how many of you are patients or patient advocates, only a couple hands went up. But you know what? This is all about us. This whole conference is about us because we're all patients. Some of us are patient advocates, and I happen to be both.
Give me 100 hairdressers, you can have 100 doctors, we'll take 1,000 patients who are diabetics, and I'll maintain their A1Cs as well as you will for half the price, and I'll bet you $100,000 that I can do it. Anybody. I know I can because we've already done it. So we've done this with hairdressers. They're better listeners. They're trained to listen. If they're not good listeners, they're no longer hairdressers. Clinicians are trained to give advice. And no offense, it's just that's what they're trained to do. They're not trained to listen. So MI comes really hard. Motivational interviewing is tough for a lot of clinicians because they're so used to telling you what to do.
So I'm going to talk about encouraging changes hopefully that people want to make themselves, using mHealth, but doing so in a way that really is getting smarter about emotion. So, and helping the technology be emotionally intelligent and helping people become more emotionally intelligent about how they make changes in their lives.
Social cohesion, multiplayer, is the cause for this, that at the societal level, if we really want to make a dramatic change in health, that it needs to be multiplayer. The Peloton. I thought, what is the largest multiplayer behavior change experience? Can anybody guess why I put this up here? It's the Hajj. Anybody else, though? So, roughly 1 billion Muslims in the world today. If you are practicing Muslim, you are obligated to pray 5 times a day. That's 5 billion moments of meditation every day from this community.
Behavior, they found, is a measure, not a goal. So they started building technologies that were less about behavior and more about being. Quiet time, reducing multitasking, eliminating tension, focusing on strengths, having breakfast, expressing gratitude, connecting to others, breathing calmly, and being confident that downtime was well spent.
Readmissions, hospital readmissions for Medicare beneficiaries is a very hot topic in my world. It's all I think about personally, but so I don't know if people are aware here, statistically about 1/5 of all Medicare beneficiaries discharged from the hospital are readmitted to a hospital within 30 days. So there's this emerging consensus that a hospital readmission within 30 days represents, probably an error. Now there are some readmissions that are planned, but they're probably are related to quality and or safety gaps. They're certainly quite expensive. So it looks like a win-win-win to work on hospital readmissions.
Specifically in the area of smoking cessation, which is what I'm going to focus on today in this program I'll talk about, there's a very powerful effect of social networks on decreasing the probability that someone's going to smoke. And it also, this idea of cascades of quitting, that someone will initiate quitting smoking and then others in their social network will do the same. And it extends out to 3 degrees of separation.
Our approach has been to look at a scalable, remote, just-in-time continuous care, a platform that incorporates principles of health behavior change and takes advantage of low-cost people trained in health coaching as opposed to focusing on sending people or having physicians or nurse care managers be the first line of defense here. And the untapped resource of family members or informal caregivers.
I think the VA is positioned to do something and model it because of the size of the system it is, because it has one database, because of a lot of reasons. We have an opportunity to model things and demonstrate them and capture the data that just isn't possible in the private sector.
Behavioral economics tries to help us understand why we make irrational decisions or seemingly irrational decisions. So think of behavioral economics as the combination of real classical economics, where you would think that, where everybody makes a decision based on the economics, based on self-interest, based on what's in it to them, based on the facts, and cognitive psychology, where people make decisions based on emotions, based on their surroundings, based on lots of other things. And you put those two together and you can really start to understand why people make decisions that seem to be irrational.
So why the growing interest in behavior change? Because I think it is growing, and the cynical or pragmatic part of me sort of says, yeah, because they're at least threatening to start paying us for outcomes instead of visits. And when you contemplate getting paid for population health, that's behavior change. That's not I operated on your heart or I got you to come to the office. It really will be things that only occur through behavior change. This is a slide that I promised myself about 8 years ago I would put in every slide deck. I haven't failed. I think these two questions are really critical. They're very seldom asked, and they're almost always answered. They're answered before the conversation starts, so you know who you're protecting, who you're taking care of, and you know where your home is. But I would say ask yourself for the sake of what first, and who's really in this together. I see healthcare as too long been taking care of itself, and I think the problem space for anything we've been talking about in the last 2 days has to be at least as big as the community.
I'm going to tell you about a few of our studies. The diet study, which is a text messaging intervention for weight loss. SMART is a brand new clinical trial that we're starting to do mobile, social, and other applications to do weight loss among college students. And finally, a Facebook Connect project, which is just in semi-conceptual stage at this point. And then describe at the end some of the things that I see as focus areas for the future.
What I want to begin with, though, is a little bit of good news and talk about this notion of sustainability, one of the themes of the conference, and to present to you what I think is very unique data, 8 years' worth of data on a wellness and disease prevention program. This program is called Health Pass, and it has a variety of components, including a recruitment strategy, health risk assessment, confirmed biomedical screening, individual counseling as needed, digital health coaching. This is the same kinds of digital health coaching that Vic talked about in his address. Referrals where necessary to additional resources, communications with continuity of care, educational information, and integrated into the primary care environment.
I said that time may change me.